with the second wave across the length and breadth of India. I don't have too much of time, so I think I'll straight away request my slides to be put up, where we can try and share with you what we have done for the past 1 year at the Tata Memorial Hospital, one of the largest and busiest cancer hospital in the region, if not in the world. So can I have my slides being displayed by the organizers?
Yeah, Trevor, can we have slides, please? So I think you can start talking, Sailesh. I think the slides will be there very shortly.
Fine. So as I look at it, Tata Memorial is an exclusive cancer center. And last year, when the pandemic set in, we took a conscious decision to ensure that we will try and continue cancer care as well. We could coordinate with the local authorities in the entire city of Mumbai to identify hospitals which would be looking after COVID patients. But when it came to cancer and COVID, we decided to segregate our hospital into definite parts where we would be able to keep our COVID with cancer patients as well as cancer patients without COVID. This, of course, required a huge amount of organization. And once I have my 3 or 4 slides put up, I would be able to share with you as to what we exactly did in terms of utilization of our manpower, deployment of our manpower, as well as how we went about trying to segregate our patients. So here we have the presentation, and I start off by sharing with you that in the first 5 weeks itself of a national lockdown, perhaps one of the biggest lockdowns in the world last year, the department which I lead, we could do 494 major operations without a single mortality, despite the fact that we had a first wave of a major pandemic last year. Can I have the next slide, please? So here was the background, that this was data which was collected over only 5 weeks last year, out of which we had 494 elective surgeries. You can see that we had a selection bias. We opted for patients with low risk of anesthesia. But on the other hand, as far as complexity grading was concerned, we had a large number of operations which were higher grade complex surgeries. And yet we had very acceptable high-grade complications. And even when we looked at patients who were more than 60 years of age compared to those who were less than 60 years of age, we did not have a major challenge. We, of course, involved a lot of clinical work as well as a 24/7 lab, which was constantly evaluating and testing our staff as well as patients for COVID-19. And even in the post-operative period, we did test some of them, and some of them did test positive. They required some kind of a support, but in terms of surgical outcome, we realized that we could still carry on with our services. This was one major message that we got last year, right at the beginning of the pandemic, and I'm pleased to inform you that we continue doing the same. Can I have the next slide, please? So broadly speaking, you can see what we did at the administrative level, at the cancer care level, at the patient-directed level in terms of our hospital preparedness, as well as what we could do in terms of directing our employees. So what we decided was that we would have a dedicated core action group comprising of all stakeholders who run a hospital, including a lot of clinicians and young clinicians, which was led by a very active and energetic administration. And then, of course, around-the-clock daily briefings, if not more than once, twice, thrice a day. And then we started off gradually with less complex surgeries, but as our confidence grew that we can manage those who are with COVID and without COVID, then we started to also expand the scope of our services. Initially, we started off 1/3, but today, even in this second wave of this pandemic for which we are all meeting today, Tata Hospital has continued 80% of our elective cancer services while we are able to still manage the COVID which is ongoing here. We also established certain areas in the hospital which were like fever clinics or areas where we could hold up patients. Our patient numbers and volumes is our strength, but it's also we are victims of our own success. And so it's not been easy. And we've had a fantastic group of doctors. We run the largest training, super specialty training program in the country for cancer care, both in surgical oncology, medical oncology, radiation oncology, so on and so forth. So it's been a lot of work, but this hospital prides itself in its service. And we've been able to take care of our staff. A large number of them have tested positive in the last 1 year, but we've made arrangements in terms of their quarantine, their tracing, taking care of them, keeping up their morale well, identifying definite areas in the intensive care which are for COVID and other areas or other intensive cares where it is no COVID. And we are able to carry on elective services. Next slide, please. So this is my last slide, and you can broadly see we are a complex of about 5 buildings. But what you see is the old structure where we have segregated our services. We have a new structure for the last 10 years where there is nothing to do with COVID. We have our outpatients clinic as well as the private wards in this particular building. And then with the help of the Tata corporate group, we could set up very large tents to make sure that we are able to first patients when they come in, before they get a chance to come in the hospital, they are looked after here, they are made comfortable here, we await for their RT-PCR tests, and then we decide how to guide them for further treatment. This particular area is also now being used for a social cause, for a good vaccination program where more than 600 people are vaccinated as a part of our social commitment to the society and the place where we live. With this, I think I'll stop. I would rather listen to everyone and we can
Sure.
discuss.
Thank you very much, Sailesh, and hopefully we will get a chance to ask you more questions and in the panel discussion. So thank you very much. Now, I've got a great pleasure in welcoming Dr. Guleria, who is the director of All India Institute of Medical Sciences in Delhi, which is considered to be the most premier institute of India, and is perhaps the place where all the policies and SOPs are implemented for Government of India. So welcome, Dr. Guleria. So if you can please turn on your camera and mic, please.
I can turn out my mic, but for the camera, I need the host has to turn it on first.
Okay, fine. So can we, Bernard, can we start Dr. Guleria's camera?
It says the host has stopped it.
Let me just try and see if we can just.
Yes.
Yes, you are on, Dr. Guleria. Thank you very much.
Thank you very much for inviting me. I'm really grateful for the opportunity to just give a brief overview of what the All India Institute of Medical Sciences has been doing over the last 1 year. And are my slides visible?
Yes, they are.
Okay, so this is an unprecedented crisis, which we all know started in December 2019 and has affected almost all countries globally. In India, the first case was reported on the 30th of January 2020 in Kerala, and we've had a huge surge subsequently. The world is currently, as we all know, undergoing a second wave of COVID-19 pandemic, but it has really hit India in a bad way. If you look at this data, which is a little bit old, but it really highlights the fact that if you look at the curve or the number of cases as far as the first wave was concerned, the second wave has outstripped it by a huge margin. And what has really caused a huge problem for us is the rate of rise. The steepness of the curve is also associated with the huge strain on the healthcare infrastructure. So I'll start with what we did more than a year ago and how we've sort of tried and adjust that to the current surge that we're seeing as far as COVID-19 is concerned. So we're all aware that last year India adopted a lot of aggressive strategies like a lockdown, physical distancing, universal masking. There was a political will and a lot of aggressive testing strategy. We started off with very few labs which could do RT-PCR for COVID-19 and crossed almost 2,500 labs with a huge capacity. Zero surveillance is also done. And of course, as has already been mentioned, vaccine program was also adopted. So way back in January itself, travel advisory was issued on the 11th of January 2020, and subsequently we had guidelines which came up in which many of us were involved. We had the first lockdown on the 24th of March 2020, and subsequent unlocking was done. This gave us time to prepare in terms of PPEs, ventilators, and infrastructure, which we were able to do pretty well as far as the first wave was concerned. Like I mentioned, we started off with just 15 labs across the country, and now we have more than 2,500 labs which are able to do testing as far as COVID-19 is concerned. We've also now started what is known as INSAGOG, which is a network of 10 labs across the country for genome sequencing and to pick up the variants which are now emerging and causing a huge concern. Vaccine, we're already aware. We have now our own the Covaxin, which is made by Bharat Biotech and the Serum Institute of India, making the AstraZeneca vaccine, both of which are being made in India and are being used. We also have now the Sputnik V vaccine, which is also in collaboration with another company, Dr. Reddy's laboratory, being sort of made in India and should be available in the market very soon, because it also has got emergency use authorization. Other vaccines have also now been approved in principle, which have not sort of gone trials in India, but the regulator has now approved all the vaccines which have been approved by regulators in the US, UK, Europe, and even in Japan, or by the WHO. A lot of manufacturers have started making PPEs and N95, and now we are actually in a position that we are producing a large amount of PPEs which we could even export. India has also been involved in a lot of IECs, and the media has been actively involved as far as this is concerned. As far as the All Indian Institute of Medical Sciences, New Delhi is concerned, many of us, including myself, were involved in the National Task Force formed by the Government of India. We were involved in making national guidelines. We've just sort of released our guidelines a few days ago from the All Indian Institute of Medical Sciences and from the National Task Force and the Joint Monitoring Group of the Ministry of Health. I'm also part of the Empowered Group created by the Prime Minister's Office to develop strategies for the country. And this is a multi-sectorial group of different ministries which tries and coordinate to make sure that whether it be human resources, whether it be equipment, or whether it be things like oxygen or other strategies are all sort of worked in, done in cohesion. I'm also chair of the clinical research group of the Indian Council for Medical Research as far as trials on COVID-19 are concerned. The key challenges that we realized we were facing 1 year ago, this is way back in February of 2020, was protection of healthcare workers, motivation of our healthcare workers, because there was a lot of panic at that point in time. This was a new viral infection. People were not sure about it. Even now, there is a lot of panic with this huge surge of the new of the variants which are causing a rapid spread of the infection in the community. There was also immediate need to increase the ICU beds, and we had to develop protocols based on whatever literature was available as far as treating was concerned. And since we were having now a common pool of people who are going to manage COVID-19, it could be an ophthalmologist, it could be an obstetrician, or it could be someone from other departments. They had to be really given training on infection control and managing COVID-19 as far as the basic principles were concerned. Since we are a national institute, we were also involved in mentoring and capacity building of other institutes across the country. And we were also given the task of generating awareness on COVID appropriate behavior among staff and public. So what we did was, in February, I set up a COVID-19 task force, and we formed subgroups in the institute. We formed a resource management committee so that we could make sure that all resources required for the hospital had a smooth flow. It could be N95 masks, it could be PPE, it could be other equipment. For example, we realized very early that we will need more dialysis machine. So in February, before there was a huge rush, we ordered 5 dialysis machines, 2 for our various centers and 1 for what we had called a COVID suspect ward. Human Resources Committee was formed so that we could use all our resources from whether it be the nursing staff, whether it be the technicians, the research officers, or our residents, or the faculty. And similarly, we had various other committees which were for training of our doctors and other staff as far as infection control practices were concerned. We also formed a diagnostic management committee so that RT-PCR kits, VTM, viral transport media, swabs, and other these kits were regularly available so that we would not run out of them. I would have a meeting every day, and I had a meeting today also of our faculty members, nursing officers, residents, the OT technicians. We all meet in the morning. Sometimes meeting goes on for about 1.5 hours, where we discuss issues which come up on a day-to-day basis. Every day there are new challenges that we face, and today I was very keen that we also really push on issues of addressing mental health issues and stress, because the number of cases has become so much, and because of the mortality that happens, there is a huge stress that our healthcare workers are facing. And we got our Department of Psychiatry, which is already working on a helpline to become proactive and develop strategies of reaching out to healthcare workers in this time of, I would say, stress and misery to some extent. And then we have reorganized and prioritized our hospital services so that cancer care doesn't suffer. The essential services like trauma continues, and other services like blood transfusion and others, which we were routinely doing, are also continued. And the emergency service continued throughout. So this was the strategic response that we have, various things that we continue to do. We also focused on research on COVID-19 because we are an academic institute, and I'll come to that. And academic activities, we try to continue as much as possible. We have undergraduate students, we have postgraduate students, we have postdoc, we have PhD students, we have fellows, and we have a huge academic activity as far as the institute is concerned. So what we did very quickly was we reorganized our National Cancer Institute. This is a very large cancer hospital, which has the capacity of almost 700 beds, and is also having a huge setup in terms of state-of-the-art cancer facilities. We are in the process of also starting a proton out there. The guest house or the Vishram Sadan, which was for the attendants of the patients to stay, was converted into a COVID care center, and the ward and ICU was converted into a COVID area. Our trauma center also was converted into a COVID hospital, and this was basically because trauma had come down during the lockdown, and we quickly shifted our trauma patients, our head injury patients to the main hospital, and we were able to convert this into a COVID hospital. We ramped up the screening area in the main emergency so that there was a good triaging done in terms of the red zone, the yellow zone, the green zone, and try to decrease as much mixing of non-COVID and COVID patients that we could do. By this, we were able to increase our COVID dedicated strength to almost 1,700 beds, with about 125 ICU beds, which we increased to 250 later on. During the first peak, we were having 800 to 900 patients admitted in these centers, and this had gone up to close to 1,000. This is something that we've seen now again. We have again having a similar number of patients, but now because of the fact that these patients are more sick, we have done a lot of triaging in terms of oxygen requirement. So I've opened up more places. Our private ward area, what we call the new private ward area, has been converted totally into a COVID center for our staff and their relatives. And we've done triaging so that the top floor has all compressed piped oxygen. And here you can give high flow nasal cannula, you can give NIV, and you can give high end support to the patient. The floor below has oxygen concentrators, and if once the patient improves, he's shifted down to the floor below so that he can now get oxygen through an oxygen concentrator, which could be a 5-liter one or a 10-liter one. If he's a little better, then he comes down to the ground floor, which is basically non-oxygen supported beds, but where you manage patients for their comorbidities. It could be sugar control, it could be other things like dialysis and things like that. So trying to try it so that we can conserve oxygen, because there was a huge demand and there was actually a shortage of oxygen which happened for a few days. This is our National Cancer Hospital, which you can see. The building right at the end is the hospital itself. The central building here is the OPD area. This is the auditorium, and this is the research block at the back. This is the cancer hospital, which is converted into a COVID hospital. This is the this is the picture from the ground, and the building that you see on the left is the Infosys Vishram Sadan, which is the for patients to attendants to stay, and patients who are going to be on chemotherapy to be able to stay so that they can come regularly to the hospital. This is a trauma center, which is again are having around 260 to 270 beds. We converted this also into a COVID hospital. The area hospital behind it, which we were going to inaugurate and we have now started, was the Burns and Plastic Surgery Center. There also around 100 beds we have now opened up, out of which 30 beds are ICU beds with ventilators and other things. The challenge was basically machinery and equipment. We needed ventilators, we needed high flow nasal cannulas, we needed non-invasive ventilations like BiPAP. And very early, we started repeat orders so that we could get this. It was a big challenge later on because many of them were not available in the market, and we had to really ask for donations also. We started looking for supplies of PPEs. We actually did in I remember last year in January, February, in March itself, there was this whole issue of shortage of PPEs, and we then did a research project on seeing whether we could recycle PPEs. So we developed a whole project. This is published, and now of course it's also being quoted by the WHO that you can really recycle PPEs if you can examine them, see that there's no tear, there's no breach. They can be cleaned and they are hung in a room which using a fogging machine, we are able to disinfect them, both the PPEs and the N95 mask, and they can be reused. This saves a lot. This is very useful for the environment because plastic wastage becomes less. And that point in time, we were able to do that. Subsequently, there was actually, like I mentioned, no shortage of the personal protection equipment, and this arrangement actually came down. We designated nodal officers for all our COVID areas. We developed a rotation of faculty, resident, and staff mechanism. During the lockdown, we hired the Delhi Transport Corporation buses so that we could make sure that our staff could come on time because there was total shutdown during the lockdown. And we really looked at various other mechanisms that we could do in terms of trying to support our faculty and staff, including creating temporary accommodation right near the hospital in case people wanted to stay and did not want to go home, because there was a lot of fear of carrying the infection home and infecting the elderly at home that was there. We also started doing testing. We did RT-PCR. We started doing the CBNAT. CBNAT is a cartridge-based nucleic acid amplification test, which is basically for diagnosis of tuberculosis. But the kits are now available, and we started using this. And now, of course, this is a standard of care. And the rapid antigen test, we validated a lot of rapid antigen tests. And now we have a strategy that any patient who comes to our emergency, we get the RAT done, the rapid antigen test done. If it's positive, he is quickly transferred to the COVID area. If we suspect, we get the CBNAT test done, which is basically gives us an idea, a test result in 2 hours time. The RT-PCR is done for the routine people who come for procedures, who are coming for routine procedures or for surgery, or for our staff, so that the turnaround time is around 6 to 8 hours. We've also developed protocols for clinical management of COVID-19 that is available both from the point of view of on our net and on the Ministry of Health and Family Welfare's website. We have developed basic management protocols on various strategies. We realized that with the excessive use of steroids, there was a huge increase in the blood sugars in our patients, and there was a strategy of the whole issue of managing diabetes. So simple flowcharts were made, which could be put up in the ward, which could be given to patients who were managing themselves at home or at the time of discharge. We also emphasized on teleconsultation. Infection control was something which was very, very important. And we also felt that there has to be dignified management of dead bodies. So guidelines were issued on dead body management and making sure that this was done in a dignified manner. And of course, there was this huge concern of biomedical waste, which was being generated as a part of COVID-19. We started teleconsultations very early because of the lockdown. OPDs were closed. Until last month, we had really done 211,589 teleconsultations. We, in our guest house, started what we call the contact facility. This was the COVID-19 national teleconsultation. We did this in the guest house so that the undergraduate students who had volunteered, our own faculty, and some of the residents could actually stay there and be able to handle calls 24/7. And this was useful for calls not only from doctors who wanted some advice on the management, but for public and for patients. And we gradually started our outpatient department when the cases had come down after the first wave. And that also led to increasing number of patients that we started seeing in the outpatient department. So this is the non-COVID care. Like I said, we really made sure non-COVID care did not suffer, and therefore we had a lot of teleconsultations, we had a lot of outpatient cases, and surgeries, dialysis, everything else was continued. Also, we have now seen almost more than 18,000 patients who are COVID positive in our setup. We have done dialysis of COVID-19 patients. This number is not correct. We've actually gone up to 3,000 right now of COVID-19 patients, and that is something that we've done. As far as training is concerned, we really started a lot of activities for our staff and then for the general public and for other doctors. Based on what was recommended by the Government of India, we started what we call EICUs. And twice a week on Tuesday and Friday, we interact with other hospitals in the country. I've probably now interacted with more than 500 hospitals on COVID management strategies and how one has to look at things like steroids, remdesivir, tocilizumab, what is the role of plasma, and other such things, and of course, post-COVID sequelae. We've had various webinars which are available on our website, teleconferences, online training modules, more than 500 have been made, and we have done huge online lectures. Today, we did an online lecture which we are trying to set up what we call state-level centers of excellence so that they can teach the doctors at a primary health level of COVID management, and from home management to home isolation to basic treatment strategies to the role of steroids, to the role of remdesivir. And today we had a talk on the role of anti-IL-6 therapies. So all of this we're trying to do in terms of modules so that they can be disseminated to doctors, because the fear is that the pandemic is now moving from larger cities to smaller towns and may also go into rural India. And therefore, we need to have training modules and strategies where doctors in that area can also be able to treat COVID-19. Very early, we realized that one of the major things was to have our healthcare workers protected. And therefore, using our hospital infection control team, we started training, and we've trained more than 33,000 of our employees, both permanent and outsourced employees, for infection control practices till now. We have what we call a Saral platform, which is basically used for undergraduate training as part of our teaching program. We converted this online platform into a training platform with modules for training of interns, nursing officers, OT technicians, and this has also been very successful. And we continue to do this because I feel that it has to be a continuous process as far as infection control practices in any hospital.
Dr. Valeria, sorry, you have what, another 2 minutes?
Yes, I'm just about to finish.
Thank you.
We also had various national excellence program, ICUs, capacity building, and national clinical grant round, which we even did with the University College London. Twice we've done it with UCL, and we are also doing that. We've also done international training for SAARC countries, which is the Southeast Asian region countries, including Maldives, Mauritius, and Nepal. Research has been another thing that we focused on. We created our own intramural grant. And in the first phase in March, we actually gave seed money for 63 research projects for COVID-19 out of 178 proposals that we received. More than 200 papers have now been published. And we have a lot of collaboration with UCL, with IIT Delhi, with IGIB, and therefore a lot of research activities are also being done. Academics continued, online classes, virtual case teaching, all of this was also done. And like I mentioned, we had various portals. I'll just give you a brief overview. We started off with this booklet, COVID-19, Be Careful, Not Fearful. This was for the public. We have a COVID portal at our AIMS website. A large number of videos have been uploaded basically on looking at things like COVID in the elderly, how to wear a mask properly and such things. Plus for the ministry also, various things have been uploaded. We have a helpline, the Contact COVID-19 National Teleconsultation, and even an email helpline, which is run by our trauma center. So I'll stop here. Thank you very much.
Thank you very much, Dr. Valeria. And that was an excellent perspective about the issues and learning points. So once we have all the panelists, we'll take the questions for all. So now I've got my great pleasure in welcoming Jonathan Brotherton, who is the Chief Operating Officer, and Professor Paul Cockwell from University Hospital Birmingham. University Hospital Birmingham is one of the largest trusts in the country, and we had two big surges, both in the first wave as well as the second wave. We had more than 200 ITU beds at the peak. So Jonathan and Paul we're two people who led this reorganization, and it'll be great to hear from them. So over to you, Jonathan, and then Paul.
Thank you, Wasim, and thank you for the invite to speak today. And my thoughts are with you all at this incredibly difficult time. As you say, Wasim, my role is the day-to-day running at UHB, which is one of the largest group of acute hospitals in the UK, with 2,500 beds, £1.7 billion turnover, and serving a population of around 1.2 million people. And Birmingham in the UK was probably hardest hit in the whole country with both waves, and 11,000 patients that were COVID positive were admitted to UHB during the pandemic so far. And that's around 40% higher than the next nearest organisation in the UK. So I hope some of the information today, which I will keep brief because a lot of it does actually mirror what Dr. Galera has just outlined, is of use, but clearly you're going through a very difficult period as well. So during January of this year, which was our most recent peak, in UHB we had 211 patients across our ICUs, with nearly all of those level 3, with about 1,100 COVID patients in our beds at any one time. Normally our ICU capacity is 70 level 3. So with that kind of expansion required, then we had to reorganise things pretty quickly around our intensive care units, our emergency departments and our wards. And I thought it would be best just to highlight some of the highest impact interventions in the hope that it is in some way helpful. So on to the next slide, please. In terms of capacity, the highest impact measures we could take really were summarised into senior decision making and 24/7 hospitals in terms of the senior and junior medical staff to ensure clinical decisions were appropriate in the context of the limitations on our most crucial resources. And those resources are the ICUs, the beds across the wards, and indeed the oxygen supply and ventilators. Also, we had to deliver a massive ICU expansion as outlined, and that was broadly through 3 key elements. One was space, where we used either double bed spacing, where patients across the ITUs were doubled up, or we used multiple theatres across our hospital estate to act as ICUs. We had to put significant numbers of extra staff in. Over 1,500 medical and non-medical reservists were rapidly trained and deployed to work alongside our ICU professionals. And also the staffing models, where we had at times 1-to-3 ratios for quite protracted periods of 1 ICU qualified nurse to 3 patients with non-ICU reservists working alongside under the direction of that nurse and under the direction of a consultant, often covering a dozen or so patients at any one time. There were care teams deployed alongside them as well to take away some of the non-essential ICU tasks to improve the care for patients and also make sure that the ICU trained staff were doing the things that they had to do. And Paul will expand on those points shortly. In terms of interventions to maximise hospital flow, the way we move patients through our hospitals, probably the highest impact thing we did in the most recent surge was the setup of rapid testing labs across our emergency departments and assessment units. And we set those up in December, just as we were going into this latest wave. And pretty much straight away, we were up to testing nearly 400 patients a day. And that was all admissions, irrespective of their presenting condition. And that gave us a turnaround time of about 3 to 4 hours, as opposed to 30 hours through the main labs. And of course, if you're waiting 30 hours to get a result back, the patient will have probably moved through 1 or 2 departments and wards after arriving in hospital and subject other patients and staff to cross-infection. And we would significantly reduce in-hospital transmission through testing 400 patients a day. And we did that when we had around about a 40% positivity rate during the peak in mid-January. That's asymptomatic and symptomatic patients. And now we're testing less than 1% positive each day, and we're still maintaining those 400 a day. The hot and cold split and the pathways was also a very high impact intervention we made, with repurposing whole hospitals as COVID secure hospitals to carry on with cancer and other essential surgery. So we removed all of our medicine from one hospital and replaced it with surgery and alternatives to level 2 ICU care, and also reconfigured parts of the other 3 hospitals so that they were as COVID secure as we could make them in order to increase public and staff confidence in accessing the health service again because we were seeing a real reluctance for people to come in for fear of what might happen if they got COVID whilst undergoing major procedures. The next slide, please. And then just a final couple of points. The highest impact measures around staffing were largely around PPE, certainly during the first wave, slightly less so during the second wave. We had to build up trust and confidence in staff that we had the supply line to ensure that they were able to work as safely as possible whilst caring for this massive rise in patients with the pandemic, as part of the pandemic. Hospital-based leadership, which Paul will expand on more, but this essentially gave very local control and ownership with some very clear steer and direction about what we were trying to achieve at a hospital level, at a ward level, at a floor level across all of the hospitals, and Paul will go into that. Communications was almost constant reinforcement of the plan, and that was necessary not just so people knew what was going on, but more so to de-risk things at an individual or a team level, given the constraints that people were having to work within and the rational application of healthcare that was being applied. And then finally, well-being was crucial, both just areas for staff to recuperate and recover, psychological support available in the moment for hot debriefs, particularly for ICU staff and staff working in ICUs who wouldn't ordinarily work there, and then how we manage the longer term effects from that. We also applied significant system interventions where we pulled resources across multiple healthcare organisations in Birmingham to make sure we maximise the amount of staff coming into the ICUs and wards from all organisations, pulled the PPE supply across community areas as well as acute areas to ensure that we manage patients at home as well as in hospital as best we could, joining forces on procurement and the distribution of equipment, including ventilators, pumps and so forth, and ensuring that the vaccination programme was effectively rolled out as quickly as possible, with field hospitals also being established around the country and one in Birmingham with the support of many organisations. And colleagues are going to talk about elective care a bit more, but we had to re-clinically prioritise all of our surgical treatments in order to make sure that we're approaching the backlogs of patients that are built up in the most clinically appropriate manner. And during the pandemic, we've managed to maintain the majority of cancer treatments and other time critical care, perhaps not with as timely as we would have liked, but certainly maintain the services and kept patients being treated. We have had to introduce some alternatives to ICU with level 2 alternatives, providing resilience ahead of the next surge, as we will expect to see more patients admitted to ICU, thereby restricting elective access. So it's crucial we maintain those, we build upon and maintain those alternatives. And the better connection that we've managed to establish between GPs and specialists through use of what we call advice and guidance, rather than straightforward referrals into our secondary care specialists. And we now manage 50% of our non-cancer referrals through advice and guidance, which is essentially an online service. And of that 50%, 40% are being managed with advice and therefore not being added to a waiting list, which has grown significantly. So I'll probably pause there and then hand over to my colleague, Professor Paul Cockwell.
Thanks very much, Jonathan. These really are extraordinary times, aren't they? And our thoughts are with you from the UK, because we've just come out of what I've called here wave 3 in the UK, and we can only imagine what the situation must be like in the healthcare system across India at this current period of time. So just to pick up two very specific things related to what Jonathan overviewed there for you. The first is really how crucial we found it was to be able to show the organisation what the models of care were through the COVID-19 pandemic. So we communicated very heavily right into the clinical and non-clinical teams. So we were sharing the care models. And one of the things that we focused on as the numbers went up was to get people realizing that we had to designate all clinical staff into the intensive care unit who weren't designated into other clinical areas. And needless to say, that's a huge challenge. You have to take your staff at an organization level with you to be able to do that. But in doing that, you must be able to protect all other areas as well. And we did that through developing local leadership models and agreeing staffing for each acute care area, and also defining what minimum safe staffing looked like it's very easy when you're overwhelmed for those critical area clinicians to be so overrun that they start to go off sick with stress, or indeed they start to go off themselves with COVID. And therefore, it's really crucial to designate what's actually safe and what's a realistic expectation for any individual clinician to be able to do. And you can see some of the rules that we ran with under inpatient care, which included shifting our major ITU hospital to a 4 days on, 4 days off shift system for the large majority of medical staff. And that system worked well. It allowed us to protect people and give people enough time off so that they could come back refreshed. Next slide, please. And then the second thing for me to pick up in a little more detail from what Jonathan's outlined is how we dealt with the huge requirements for the intensive care units during this particular period. And we set up an organizational hub. And here's a process map at the center of which you can see the organizational hub that we call the ITU Medical Reservist Hub initially, although we subsequently changed the name of that. And that then created a very clear pathway through which clinicians could move into the intensive care unit. In the first wave of ITU provision, we did a lot of training before people went into the intensive care unit. But as that first wave developed, what became clear to us was that the large majority of valuable training needed to be on the job training. And as we moved through the second and third waves, as people were going into the intensive care unit, what we were doing was bringing people in who were intensive care unit naive, and that was from a broad range of specialties, and really fast tracking bedside training for them within the intensive care unit itself. And that was a very effective development model and brought people through to a level at which they could function, both in terms of working at the bedside with nurses. So we had consultant medical staff working shoulder to shoulder, assisting nurses at the bedside, and also where people had specific skill sets, we were rapidly able to develop skills where individual physicians were able to rapidly function as consultant intensivists. So that should give you a deeper flavor of two specific areas that we focused on. And Jonathan's given you an overview of the major things that we did to try and deal with the last wave of the pandemic that we saw. And I've now finished my particular part, so we can move on to the next part of the presentation.
Yes, thank you. Thank you very much, Paul. Now I've got a great pleasure in welcoming Dr. Caroline O'Keefe. She is the Clinical Commissioning Group Lead and Urgent and Emergency Care Lead from North Hampshire. So over to you, Caroline.
Thank you, Wasim. Next slide, please. So what I want to do, or what I've been asked just to talk a little bit about today, is the logistics from a primary care point of view of setting up a COVID oximetry at home service. I won't repeat, because I know this has been well covered in the first webinar, the benefits of COVID oximetry at home, but the essentials being to identify early silent hypoxia, to keep the majority of patients at home and away from a hospital. Sorry, previous slide, please. In order to get the right people into hospital and keep the majority at home. So as I say, I work in North Hampshire, and we came together early in the first wave as a cohort of 6 primary care networks, 15 GP surgeries, and we cover a population of around 230,000. And we decided to co-locate our COVID oximetry at home service together with a hot hub. And that brought a few positives with it, but not least, as we've already talked about, the huge benefits of being able to offer rapid point of care testing. We had access to an immunofluorescent lateral flow test, which gave us a positive reading within 15 minutes. And that was hugely valuable. We tested all the febrile patients and any patients with any form of respiratory symptoms who came through our hot hub. And obviously that gave us huge benefits of early identification of patients with COVID. So we set up our service on the 2nd of November. We ran a hot hub through our first wave, but set up the COVID oximetry at home service as we were entering what certainly in the south of England became our second wave. We ran it as a single integrated platform. So we made sure that it was an in and out of hours service, and we staffed it led by a couple of fantastic advanced nurse practitioners. supported clinically by myself, but also supported by care coordinators who are non-clinically trained people, but who are able to work with some of the sort of the processing and the contacting and talking to patients. And at its simplest, a COVID oximetry at home service is essentially provision of a pulse oximeter, allowing patients to monitor their own saturations at home and to identify early those who deteriorate and those who become hypoxic. And our key, and what I was passionate about really as I set up this service, was to keep it simple. So at its very basic, we started with 700 pulse oximeters, which were given by NHS England, and we made up simple envelope packs containing a series of instructions, some links to a YouTube clip as to how to use a pulse oximeter, some paper diaries, and a return envelope. And that was it when we started. We since developed it. We had a very simple, again, referral pathway. I was very keen that this was accessible to all of my primary care colleagues across North Hampshire. So we had phone access through 111, which is our out of hours service, and access via email. We were happy to take referrals into the service from wherever. And as I say, we started with a pretty simple setup, which was paper-based. We pretty quickly went to a text-based service, and we used something called Accurix, but essentially a text-based service where patients were sent automated text 3 times a day, allowing them to enter their observations. And we recorded that on a spreadsheet. And then about 8-10 weeks into the service, we moved to a sort of further digital solution called In Healthcare, which allowed it was a web-based service allowing a dashboard of data that I'll show you in a second. But I think the important thing is the IT solution wasn't the important part. At its very simplest, it is receiving patients' data. The lead advanced nurse practitioner oversaw the data as it was submitted, obviously identified any deterioration and acted where appropriate. Really important for those people who didn't have access to phones or the ability to send their data in via text. We were very comfortable that they could do that via a paper diary and a landline. Next slide, please. So this was our current situation. As you can see, this was our wave sort of earlier this year, and our numbers have decreased significantly. Our hot hub at the time, we've seen 4,620 patients through there, and those are community-based patients who presented with either a febrile illness or respiratory symptoms. And we kept the vast majority of those people at home. And I think that's what's so important. We had to send just over 300 patients into hospital, either for an admission or for further investigation. But over 4,000 of those patients we were able to manage safely at home. In our COVID oximetry at home service, we've had 833 patients through the service. And interestingly, of those 833, we identified silent hypoxia in 116 of them and admitted them. But only 2 of those died, and that's a huge change from the mortality with silent hypoxia that we saw in our first wave. So this early identification does seem to be critical. Next slide, please. So just a little bit on some of the lessons that we learned as we got busy. So at one stage in the peak of our wave earlier this year, we had just shy of 200 patients on the platform, each submitting their data 3 times a day. So obviously 600 data submissions a day, which was initially being managed by a couple of people. We brought some more staff on board. And again, these were non-clinicians working under some clinical leadership, but we did bring 2 extra members of staff on board. And that was when we switched to the In Healthcare platform. And you can see on the left side of the screen, just an idea of what that looked like. And that gives us a very easy pictorial sort of idea of when patients were deteriorating. I think other lessons that we learned, we did have some care home outbreaks and we had to learn very quickly how we managed those. It was really important to communicate with our local primary care teams to make sure we had respect forms, which are a series of forms that we use to identify patients' wishes, and it was so important to have those in place in advance. We saw a great impact of the vaccine. When I look of our 800 patients that we discharged, if I look at the first 100, nearly 20% of those were in the over 80 bracket. And when I now look at the last 100, only 4% were in the over 80 years old bracket. So we really did start to see the vaccine having an impact. And I think the other really important lesson that we learned was communication. I know others have mentioned that strongly as well. Communication for us with primary care, with my colleagues across the 15 practices and the area, communications with secondary care. We had fantastic input with the palliative care colleagues. So particularly when we were at the peak, we used to have 3 times a week multidisciplinary team meetings, which palliative care would attend, and would go through who we had on the service, just to identify those who maybe were deteriorating. We're now, with our cases being lower, we are doing a lot of active case finding. We're drawing down all results centrally and referring anybody who is a high risk positive. We're inviting them to be admitted to the overlook oximetry at home service. And obviously as well, we're working really closely with our secondary care colleagues, so that as patients maybe need admission and then discharge, we're able to pick them back up in the community. And final slide, please. And I just wanted to share this with you. Of our 800 patients who've been discharged, we've done some basic patient feedback, pretty simple but hugely positive. Patients really, really value this service. They find it helpful. They understand when to seek help. Very few difficulties, and the feedback has been genuinely wonderful. And people feel very supported when they're at home with what is a really quite frightening illness. Thank you very much.
Very much. So I've got a great pleasure now in welcoming Professor Kiran Patel, who is the Chief Medical Officer and Deputy CEO at University Hospital Coventry and Warwickshire, and is the Chair of Trustees at South Asian Health Foundation. Over to you, Kiran.
Thank you, Wazim, and it's a pleasure to be with you. I wish we weren't here if we weren't under such distress in our healthcare systems, but I think it's great that we're sharing experience and knowledge across the world, so it's a pleasure to be here. University Hospitals of Coventry and Warwickshire spans across 2 sites, and during the pandemic we had a 3rd site covering about just under 1,300 beds. And I'll move on to the next slide. I think one of the advantages of going last is that a lot's being covered, so I'll try to be brief, Chair. I think one of the most important things we set up early was a good governance structure. And on a daily basis, like we've heard from colleagues at AIMS, we held meetings of the medical, nursing and operational teams. And that command structure was really supported by a clinical COVID committee, which was essential to get a good transmission belt of clinical opinion and need across the organization. So we had a very good battle rhythm of governance throughout the pandemic, which stood us in good stead operationally. And that sat above all the streams of work that we've heard about from colleagues to make sure that our business continuity was addressed on a daily basis, so we could keep a tab on oxygen supplies, for example, and to make sure that we were meeting the needs for training and clinical pathways across the organization. The entire workforce needed to be addressed, so we had a big piece of work making sure that we had engagement across the organization. And communication was key, both internally and externally, and I'll cover some of that shortly. But again, procurement was absolutely critical because we saw a lot of anxiety very early on about PPE needs and testing needs, which we were able to meet. But of course, we needed to make sure that people understood that we did have a good supply of both PPE and testing for COVID. Next slide, please. I just wanted to very briefly cover some of the key points in terms of strategy and leadership. We very early on decided that we were going to meet the needs of not only COVID patients, but also non-COVID patients. So we went to great lengths to make sure that the public understood we were open to business so that we could counteract some of the diminishing attendances in conditions such as acute myocardial infarction and stroke, where we weren't simply seeing the numbers of patients one would expect. So whereas we were trying to advise the public to stay away from public, we wanted to make sure that the public stayed away unless they actually needed care. So good communication to the public was key. And then we also started to think very early on about post-COVID care and what that would mean in terms of restoring services. So to be well ahead of the curve on that. Standardization and ongoing learning was key. So to collate evidence as it emerged across the globe and to make sure that we implemented evidence-based medicine was absolutely critical so that we could standardize care and access to care. We wanted to maintain rapid access to expert advice, as colleagues from Birmingham have told us. So to get very rapid access to stroke beds, surgical beds, and to make best use of resources is absolutely critical so that we don't generate an inequity in the system. We also wanted to make sure that we weren't complacent about capacity that we had. So where we could identify the ability to support colleagues from across our health service, we would do so. And we've taken great pride in being able to provide support to colleagues across the health system locally, regionally, and nationally. And then infection measures, I think we've covered already, so I won't go into those. But some of our workforce deployment and redeployment needed to be very fleet of foot, very rapid, and the upskilling requirement was absolutely critical. Now, we did innovate because of workforce needs. People would go off sick and we'd have quarantining. So we made best use of medical students, and we tried to keep research, teaching, and training all going as much as possible throughout the pandemic. And next slide, please. And in my last slide, really, I just wanted to bring home the fact that really compassion and ethics are critical in everything we do. We wanted to make sure that nobody died alone at UHCW. So whether it was COVID or non-COVID related care, we wanted to make sure that compassion was really key to the care that we provided. And then the second issue that was very personal to me was that we wanted to make clinical and not ethical decisions, because the public were very anxious about the resources available and the pressures on the healthcare system. But we continue to impress that actually we would make clinical decisions and do the right thing for patients. And professionalism was absolutely critical to doing that. Wasim, I'm going to stop there in the interest of time and hand back to you.
Thank you very much. So can we just take off the slides and get all the speakers on a panel view for the Q&A? So if all can please get their cameras and mics. So I think I've got my first question. I'll probably direct it towards Dr. Guleria and Jonathan Brotherton. One of the big issues that has been highlighted by a lot of people is the staff well-being, because we have quite a workforce, and this includes the doctors and nurses, who are working in extremely stressful conditions. And it is just a question, as Paul said, what can be done to look after the physical and mental health of the staff? And do you have any suggestions for the wider audience? I'm not sure whether Randeep is there. Jonathan, do you want to?
I could start.
Yeah, Randeep, please.
So I think it's a very, very important issue. And as the pandemic has been there for now more than a year, it's becoming more important for us to really address stress and mental health issues as far as the staff is concerned. We have to develop strategies. One of them, of course, is developing a strategy of rotating them so that they spend some time in a COVID area, but then are rotated out and can work in a non-COVID area, and also get some time off as part of their rotation, so that is sort of a mechanism that you have it, in 3 groups that they rotate if it's possible. It becomes difficult at times when you have a huge surge that you need all hands on deck, if I may use that word, at that point in time. We've also developed wellness centers, and we've tried to reach out. The Department of Psychiatry has tried to reach out to them in terms of being able to get in touch with them. I didn't know I think my video has just started. So anyway,
yeah.
So in touch with them and be able to get in touch with the residents and be able to talk to them. Today, I felt that we need to do more than that. We need to develop strategies of talking to them and developing some interactive sessions. So we're trying to develop sessions where we talk to people and start interacting with them. Because as you see a lot of mortality happening, there are people who know someone or the other who's passed away. There is a little bit of depression occurring, and because of a sort of a burnout which one sees, it's important to start talking to people. We have a helpline and we talk to all our residents, but I think it's important now to have some group activities so that we can start talking to the residents, the faculty, and develop strategies for de-stressing, because this is something which is becoming a cause of concern.
Thank you. And Jonathan, you had this concept of 4 on, 4 off, which I think worked very well. Do you want to dwell on it?
Yes, sure. It was Professor Cockwell's concept.
Yeah, Paul, I was thinking.
We just helped implement it.
Paul, I was going to give it to the call. The person who invented the 4 on, 4 off.
No, I mean that's other services have used that particular model of care. Jonathan and I are fortunate to work in in the UK Royal Centre, or with the UK Royal Centre for Defence Medicine. And our military colleagues emphasised that to us from a very early stage in the pandemic, that we needed to be very transparent and very fair to our colleagues who were working both as clinicians and non-clinicians, and bring in systems which everybody could see and where the workload was really shared across. And it worked very well, in fact. It certainly worked very well through the first wave and then in the last wave that we've had as well. So that's a model that's well worth looking at. And if you want the template for that model, anybody, I'm very happy to provide you with it. And you can then adjust that model for your own organization, dependent upon the numbers of doctors you've got and the areas that you've got to cover, so forth.
Thank you. So the next question, I think this is very important, and this is something which is it's personally dear to me as well. Now, one of the biggest challenges we have got is that the COVID is, we don't know how long it's going to be there. But the biggest excess death is probably going to come from non-COVID, be it cancer, be it dialysis, be it diabetes, cardiovascular disease. So Sailesh, one of the big challenges is cancer services. How do we run the cancer services? Because it's not like trying to differentiate one death from the other. So how do we run a cancer service in these times and continue to run it and recover it once the pandemic subsides?
So I can tell you, Tata Memorial Hospital, just to give you an example and give you an idea, we get about 69% of our patients, not from my own state and from my city, but from all over the country. So that would mean that we just have about 30% or so who are coming from my state and my city to a referral center like Tata Memorial. Every year we see about 80,000 patients, and despite a lockdown, which was quite strong and severe in the months of April, May, and June last year, the numbers again started to come up. And by December, we had seen about 62,000 patients in person even last year. Now, the purpose to tell you this is cancer doesn't wait. COVID or no COVID, cancer doesn't wait. But that doesn't mean that people need to travel all the way across the length and breadth of India and come to Tata Memorial. The good thing has been that we have established cancer hospitals in different zones or regions of the country. We have a cancer facility in Visakhapatnam that's on the east coast in Vizag. We have a facility in Assam that is the B. Barua Cancer Institute in Guwahati. With the help of the Honorable Prime Minister and the Tata Group, we've built a big hospital in Varanasi that is in Banaras, and they are all under the Tata Memorial Center umbrella. So we have been hand-holding them, and they have gained a lot in the last years. As a result of that, a large number of patients could yet continue to go to these centers, and cancer care could continue. But for that, in a snapshot of what we have all discussed, it all involved a very strong, clear leadership. It involved making sure that we have doctors available both for COVID care as well as non-COVID care and dealing with cancers. Now, when it comes to triaging cancers, obviously, we would want to treat the low-risk cancers and the cancers which have got clear benefits in terms of short-term as well as long-term survivals. So yes, there would be a selection bias as to how much risk we want to give them and what benefit we are going to get out of that. So I don't mean to say that we have managed to deal with cancer as well as any other year, but thanks to teleconsults, thanks to other hospitals also following the Tata Hospital model as far as cancer care is concerned, we have been able to continue to about 80%, if not more than that, of our elective cancer work. Now, we have got dedicated disease management groups, and we have tried to create guidelines for people who are a part of the National Cancer Grid. So beyond the 5 Tata Memorial hospitals, we have also tried to create a chain of hospitals in the last few years. This has been a culmination of the last decade of efforts where we have a guideline which is available. We have a connectivity with hospitals where they can get an idea as to what has been our experience in Mumbai. And we've tried to emulate that. It's not happened everywhere, obviously, because local challenges and the kind of surge that you see, manpower requirements, they're all variable across cities and different centers. But that's where we have tried to push for for essential treatments like nephrology, chronic kidney disease, cancer care, cardiology, etc.
Thank you very much, Sadiq. And very quickly, Kiran, I know your day job is that of a cardiologist. Long-term conditions, how are we going to recover? What is going to be the effect of the pandemic in the long term?
Yeah, so I think we all know that more people will die from non-COVID related conditions than COVID itself. And non-communicable disease is the most significant driver of health inequality. So as we're restoring services, clearly, as colleagues have said, the prognostically relevant conditions such as cancer and cardiovascular disease are critically important to restore and or to maintain going. As in our case, we kept as much going as possible. But then we've taken a very conscious decision at UHCW to restore with respect to those services that drive health inequalities. So one of the first large-scale outpatient openings was our diabetes service, and likewise our services for hypertension and general cardiology, because we know that at a population level, these are the things that will drive inequality and outcome post-COVID. So looking ahead very early on into the post-COVID world, we made sure that we restored those services very early.
Caroline, just in terms of trying to prevent people from going into the hospitals, and this is going to be quite a big issue in a country like India with a large population, with a lot of patients having the anxiety. The moment their RT-PCR is positive, the anxiety levels really go up. Is there a kind of a simple 3-line message about what you need to do in terms of home oximetry, how patients can actually manage themselves at home and avoid going to the hospitals?
I think my simple 3-line message would be get started. Don't wait for the resources. Don't wait for the tech. Just get started. If you can get hold of some pulse oximeters and some information for patients, I think I wouldn't wait for the perfect solution. We definitely found starting with the imperfect solution and then changing it as we went along.
Dr. Guleria.
So I think I just agree with that. The government of India many months ago set up criteria for home isolation, and we're providing pulse oximeters to everyone at home and have what we call a call center, which calls up the patients morning, evening to find out their pulse temperature and the saturation, and based on that takes a call on whether they should be admitted. But those patients who cannot have isolation at home, because if you are number of people are staying together in, let's say, a very small room, then and they're sharing the facilities, then there's a whole chance of everyone getting infected. And because of that, the government set up COVID care centers, which were basically centers which were just to isolate yourself. And it was done basically in like hostels and things like that. Subsequently, for certain hotels were also taken up. So there are certain hotels which have become COVID care centers, which are just to isolate individuals with monitoring for pulse oximeter and temperature. So this is being done, and a large number of oximeters have been distributed by various states to patients for home monitoring. The only catch that I see is that you need to be able to pick them early so that they come into the hospital early rather than late. We've also had a process of teaching people how to prone themselves at home so that they can do what we call conscious proning, and that also helps in improving saturation. But what happens is that sometimes patients will call you up late in the night that now my saturation is 88 or becoming less than 88. You need to get them early into hospital rather than them, coming to the casualty very late and crashing in the emergency. So that is something that you need to teach the patients, that, don't wait too long. Sometimes they tend to stay on at home for too long, and that sometimes causes higher morbidity and mortality.
Great, thank you very much, and I would like to really thank all of you to be part of this webinar. I really enjoyed it, and I'm hoping it's going to be extremely useful for a number of people. So on behalf of South Asian Health Foundation, Academic of Health Sciences Network UK, and all our partners, we really thank all the delegates who have participated. This will be available as a recording in various YouTube channels. So thank you very much. And thank you to all the panelists for an excellent deliberation. Thank you.
Thank you.
And this is the next series of COVID-19 webinar, which is going to be there on the 14th of May. You will get the details later on. Thank you.